All right, now on to visual inspection. So our plumb line assessment here, important consideration, we want a systematic way of approaching this. So some people like to start from the head and work their way down. Some people like to start from the feet and work their way up, just as long as we have a systematic process as we're going through this. So on our anterior view, looking at the patient from the front, with our visual inspection, looking for any weight shifting onto one lower extremity. Now that could be suggestive of a lower extremity issue, could also be suggestive of a lumbar issue with compensation in the lower extremities. So that being said, we're not making causative links here, we're observing. Our pelvic asymmetry, so again, a weight shifting might cause this, or a scoliosis might cause this, or a lateral shift might cause this apparently. So we're observing the abnormality. Lower extremity alignment. Um, our any signs of distress. So look at the patient's face. Are they grimacing? What are they conveying to you? Now, if we're going to palpate for landmarks, and again, with this, there's questionable reliability, which we'll talk about in our SI joint unit, but looking at the ASISs when we're looking from the front here. Now, our posterior view, looking at soft tissue abnormalities. So look at the lumbar paraspinals. Are we seeing any differences in symmetry? Are we seeing atrophy? Are we seeing any abnormal findings there? Our scapulae generally should align with about the T7 process to give us a little bit of visual cue there on where we are in the spine. Our malleoli as well. So are we seeing a relatively symmetric malleoli on each side? The popliteal crease can be helpful in looking at lower extremity alignment as well, so on the back of the knee there. And with our landmark assessment, again, we'll talk about limited value of this with the SI joint unit here, but vertical alignment of the spine, palpating along, finding those spinous processes. Iliac crest height, give me more helpful from the posterior here. PSIS as well. Now, some common abnormalities that we might see from the posterior view, our lateral shift. So this picture over here to the right is an excellent example of a lateral shift. And this could be someone who's trying to unload one side of the spine there. This has been proposed with people who have disc abnormalities or zygapophyseal abnormalities, but essentially trying to get in a position that'll relieve symptoms. And our scoliotic curvature we might see as well. We talked about two semesters ago, musculoskeletal one, the Adam Ford flexion test that we might want to throw in as well if we're seeing any curvature that's concerning. Also, with this, our difference from side to side in muscle mass, which could again be related to atrophy on one side or both sides potentially, and possibly guarding as well. So our lateral view, our plumb line assessment, we want to look and see, does the external auditory meatus line up with the acromion, the peak of the iliac crest as well. And this is where we can observe lumbar lordotic curvature, thoracic kyphotic curvature as well. So so forgive the slide here. We're not looking so much at our vertical alignment. We're not looking at these landmarks. This is a typo. So our lateral view, this would be a good example in this picture of what we're seeing with a excessive lumbar lordosis, also known as a lower cross sign. So essentially we've got a patient here with this lumbar lordosis. They're relatively extended in their lumbar spine and increasing weight bearing function essentially on those zygapophyseal joints. And we've talked about in our health conditions lecture how that can be problematic for folks. Now, commonly with this, we can see the tight hip flexors, tight rector spinae, the stretch weakened abdominals, stretch weakened glute muscles as well. So hence the lower cross sign terminology as well. And this would be consistent with our anterior pelvic tilt. When we talk about pelvic tilts, we're not talking about change in position at the SI joint per se. We're talking about a combined abnormal position of the lumbar spine and the hips as well. So an anterior pelvic tilt looks like the pelvis is rotated anteriorly, but with this, we're seeing increased flexion in the hip and increased extension in the lumbar spine. So we might also see diminished lumbar lordosis, which we're seeing in this picture, also known as flat back. So a relatively flexed position in the lumbar spine and a relatively extended position of the hips can result in that posterior pelvic tilt that we're seeing here as well. Our sway back posture. So this would be when we have that excessive lumbar lordosis and excessive thoracic kyphosis, so a relatively forward drift there of the pelvis. And with this, lengthened back extensors and hip flexors.